Imagine a routine TEP procedure turning into a life-threatening crisis within seconds as the external iliac vein is accidentally breached during tacking. This isn't just a surgical error. It's a failure to respect the hidden vascular landscape of the pre-peritoneal space. Most residents focus on the hernia sac, yet the major vessels lie dangerously close to the operative field. Understanding the exact coordinates of these vessels is the only way to prevent catastrophic intraoperative hemorrhage during mesh fixation or dissection. But here's the detail most people ignore until the patient returns with debilitating thigh pain. The lateral femoral cutaneous nerve and the genitofemoral nerve are the silent victims of overaggressive stapling. If you place a tack lateral to the inferior epigastric vessels or below the iliopubic tract, you risk permanent sensory loss or chronic neuralgia. This surgical misstep transforms a simple hernia repair into a lifetime of neurological suffering, making anatomical mastery more than just an academic requirement. The triangle of doom is not just a catchy name, it is a surgical boundary that defines the difference between success and disaster. Medially bounded by the vas deferens and laterally by the spermatic vessels, this zone contains the external iliac vessels. Every PG student must visualize this triangle every time they enter the preperitoneal space. Why is this critical? Because any dissection or fixation within these borders is strictly contraindicated due to the extreme risk of major vascular injury. That explanation sounds good until you notice the secondary danger zone, the triangle of pain. Located lateral to the spermatic vessels and below the iliopubic tract, this area houses the femoral nerve branches and the lateral femoral cutaneous nerve. It is often the site of misplaced tacks during the lateral fixation of the mesh. Surgeons must avoid permanent fixation in this region to prevent post-herniopathy neuralgia, a complication that remains a leading cause of patient dissatisfaction in surgical practice today.
Urinary bladder injury is a complication that often occurs during the initial port placement or while creating the preperitoneal space in TEP. Patients with a history of lower abdominal surgery or those who haven't voided before the procedure are at significantly higher risk. If the bladder is accidentally entered, it requires immediate recognition and primary repair. Failing to spot this intraoperatively leads to urinary ascites, peritonitis, and an unexpected secondary surgery, turning a routine outpatient case into a complex inpatient stay. This is the detail most people ignore regarding energy use. Thermal spread can cause bowel injury that remains hidden for days. During the reduction of a large indirect sac or while using monopolar cautery near the intestines, the heat can penetrate beyond the visible surgical field. The patient may appear fine initially, but 3 to 5 days later they present with fecal peritonitis. Constant vigilance and the use of bipolar energy or ultrasonic scalpels are essential strategies to minimize this delayed catastrophic event. Choosing the wrong mesh or inadequate fixation can lead to the silent complication of mesh migration or significant shrinkage. Studies show that some meshes can shrink up to 20% over time, potentially exposing the original hernia defect and leading to recurrence. If the mesh is too small, it fails to cover the myopectoneal orifice of Rousseau entirely. Ensuring a minimum of 3 to 5 centimeters of overlap beyond the defect margins is the clinical standard required to prevent these long-term mechanical failures. Chronic postoperative inguinal pain, or CPIP, affects roughly 10% of patients and is now considered more significant than the recurrence rate itself. It is often caused by nerve entrapment, mesh-related fibrosis, or inflammatory reactions to fixation devices. Managing this requires a multimodal approach, but prevention is always the best cure. Surgeons must transition toward using lightweight meshes and atraumatic fixation, like glue or self-gripping meshes, to reduce the inflammatory burden on the delicate nerves within the preperitoneal space.
But here's where it gets weird for the patient. The appearance of a bulge after surgery that looks exactly like the hernia they just had fixed. This pseudo-recurrence is usually a seroma, a collection of fluid in the old hernia sac. It is the most common post-operative event following laparoscopic repair, especially for large indirect hernias. Differentiating this from a true recurrence requires clinical patience and often an ultrasound. Most seromas resolve spontaneously, but aggressive aspiration risks introducing infection into the mesh. The irony of laparoscopic surgery is that we can create a new hernia while fixing the old one. Port site hernias occur most frequently at the 10 mm umbilical site if the fascia isn't closed properly. While many surgeons believe 5 mm ports don't need closure, evidence suggests that in patients with high BMI or connective tissue disorders, even these small sites can fail. Proper fascial closure and the use of bladed trocars only when necessary are the primary defenses against this avoidable complication. Laparoscopic surgery isn't just about anatomy, it's about the physiological shift caused by carbon dioxide insufflation. The increased intra-abdominal pressure can decrease venous return and alter cardiac output, while the absorption of CO2 leads to hypercapnia and acidosis. For elderly patients or those with underlying cardiac disease, these changes can trigger intraoperative arrhythmias or respiratory distress. Monitoring end-tidal CO2 and maintaining the lowest possible pressure for adequate visualization is a critical safety protocol that every surgical team must strictly follow. Ischemic orchitis remains remains one of the most distressing complications after laparoscopic inguinal hernia repair, often resulting from excessive dissection of the cord structures or a tight internal ring closure. This condition typically manifests as painful testicular swelling followed by atrophy, occurring in approximately 1% of primary repairs. The critical factor is the compromise of the pampiniform plexus rather than the testicular artery itself. Recent studies indicate that venous congestion is the primary driver of this irreversible testicular damage.